Welcome to Man Medicine, where we talk about how men can optimize their health and escape the collapsing U.S. healthcare system. So today, I'm honored once again to have my good friend Felix Hay back on the show. There you go. Hi, Felix. Thanks for coming on.
Thanks for having
And
me.
today, it's actually we've timed this perfectly because we're going to be talking about weight training today and exercise as part of our overall approach to men's health, longevity, etc. And the timing's perfect because you just finished a workout there at your home gym, like not more than 10 minutes ago, right?
Yeah.
So,
Yes.
so
Apologies
that
if I feel slightly puffed.
yeah, you're a little bit swollen. I can see you glistening in sweat. Yeah, this is good. But this is a good example of the fact that we both practice what we preach, right? We are in there, maybe not every day, but we're certainly in there on a regular basis, practicing what we preach. And you're fortunate; you have a home gym. Is that right?
Yeah. I'm very fortunate. I'll see if I can just quickly show the viewers.
Oh yeah, let's see it. Let's see it.
Bit. But
It's really impressive. I'm a bit jealous.
So I've got cross trainer, big rack.
Yeah,
I've got
look at that.
plenty of plates.
Mm-hmm.
But and then I've got behind me, I've got dual squat rack and leg press as well. But I'm very lucky actually. It's been a long time in the making. I used to work out in a shed that had wool blankets to try and insulate it to make it warmer. The day I think that I decided to make this gym was the day that I went out in the winter, because I live in the UK, and I put my hands on the pull-up bar and my hands froze to it. They literally froze to it with ice, so I couldn't actually get my hands off. So that was when I was
true dedication.
I was like, this needs to change, which is how this gym was born. But yeah, I'm very lucky indeed. Yeah.
Awesome. Well, Felix, for the listeners who don't know your background, you and I actually have a very kind of a similar background, actually. So maybe would you mind talking about your educational background and what brought you into the men's health TRT space and what you're doing currently? Because it's something new that's happened. Yeah,
that's right. Yeah. So a little bit about me. So I work in the UK under the National Health System. Traditionally trained in university back. I qualified in 2005. And predominantly did pediatrics, did a stint in orthopedics, which is bone surgery, and then also burns and plastic surgery as well.
Oh, I didn't know that about you.
Yeah, I did. That's how I started. I always wanted to do emergency medicine, much like Andrew does, but there were no jobs at the time. So I ended up doing 3 years in the surgical route. Then I finally got an opportunity to go and work in emergency care. Now back then it was a slightly different model. Like even though I was predominantly pediatric trained, so working with children in emergency care, we were expected, because of our training being quite broad, to work with adults as well. So I was very often, placed in the adult ER, and vice versa in the pediatric department. So yeah, I gained quite a wealth of experience over the next sort of 15 years doing that, and then. At about that point, so probably actually 10 or 12 years in, I saw an opportunity for. Initially, I actually applied. This is something I've not discussed with you. I initially applied for postgrad medicine and got an interview at a university locally, and I had one of those sliding door moments in life where I just suddenly got an attack of imposter syndrome. Went, oh, I'm not built for this, and I actually, to my shame, went home. Instead of going to the interview. And to this day, it's something I think about a lot and think, what if I'd have done that? Where would I be now? But at the same time, it's that butterfly effect, isn't it? I wouldn't have my family, I wouldn't have my wife, my children. So it's not something I dwell too much on. But out of that, it made me realize that I wanted to work in a more autonomous manner if I was looking to go and do medical training. And the fee structure in the UK for how you could get higher education changed that year. And so I would then, and it changed for the worse, unfortunately, I would never have been able to afford to go back to university without some sort of sponsor. So I know, Andrew, you did it in the States uniformed,
right,
didn't you? Yeah,
I did. I was poor. I didn't have the money.
An option for that for me. So, but then I saw this thing, which was actually born out of America, called Advanced Nursing Practice, and it was it looked very similar on paper to the way in which medics train. So you went and did extended training in anatomy, physiology, pharmacology, and then you did all this training, usually depending on which university, which is what we call college in the UK, at which university you went to, you actually sat in with the medical school students. So you actually sort of ended up going into med school, and that's where you got your education. You were lectured by consultant physicians, registrars, and I'm not sure what the equivalent is in America when you're a registrar. You're sort of just below consultant. Is it attending?
Or resident? It would be resident. We go through a residency, and then you become board certified in your specialty. And then that's the equivalent. I think my understanding is that's the equivalent.
So I think
so that's as high as you can go.
So we got lectured by consultants, which is the highest you can go, and just beneath them, which would be your residents.
Got it.
And so we did all of that over a 3-year master's degree in medical sciences. And at the same time of doing that, you also do your OSCEs, which are these exams and vivas as well, where you basically get grilled like with real life patients, and they do have pathology, and you have to, using a targeted or full cephalocaudal, so head to toe exam, find out what's wrong with them by your history taking and your physical, as most guys refer to it. And if you didn't get it right, you didn't pass that station. And then you did that station, you moved on to the next station, and it was an intense day that day. And then at the end of it, your viva was being grilled by a bunch of examiners on the board about all different types of anatomy and physiology and pathology of disease. So it was pretty intense. And then after that, you get to take on the title of advanced clinical practitioner. And you then can see, diagnose, treat, discharge, prescribe medication for to undifferentiated patients. So patients that have seen nobody else before, and you're the person working out what goes on with them. And you can tailor that to whatever the environment is that you're working in. So for me, obviously, naturally, it was emergency medicine. And that's how I sort of got into that sort of status of that role. Now, I guess people are probably wondering how I got into hormone replacement medicine from emergencies.
They're not. They're very different, right? There's a few endocrine emergencies, right? That we obviously we see, but low testosterone is not one of them.
Somebody with adrenal crisis. That we need
that's
to
different.
sort them out. But to see testosterone related emergencies in the department.
I mean, it might feel like an emergency to the person.
It does, and we shouldn't make light of it. Some patients, it really does feel like it's a problem. But rest assured and be reassured that it's always sortable. But so all jokes aside, much like anybody that's come into this field, it was through my own misfortune. I was born with unilateral cryptorchidism back in 1982. And that wasn't corrected surgically until I was quite a bit older because I was premature. So I was on a ventilator for quite a while. It's actually why my name's Felix. It's Latin for lucky, and I had full cardiac arrest on the vent a few times. So as you can tell, my parents studied classic languages. That's why they chose this name, because Felix is a great story for lucky. So I had a sort of a bumpy start to life. Had that surgically corrected. Was always very small for my age. And as I grew up, there was lots of talk about giving me growth hormone, of all things, which my parents were very reluctant to, because back then there was a lot of talk, negative talk about it. And then there was the whole, and this is nothing to do with growth hormone, but it was just to do with the attitude towards health and media scaremongering back at the time. There was a whole thing about CJD. Or mad cow disease was a big thing because they were talking about blood being donated, and so there was a lot of anxiety around all of that kind of stuff, was things that we didn't really understand. So I didn't end up going down that route. I just got prescribed these intensely calorie dense milkshakes to make me gain weight. And they worked a little bit, but my height never really sort of caught up. So I'm only 171 centimeters, so that's about 5'7". And I was always very slight, but always very athletic. Then during my sort of early 20s, I sporadically got into weightlifting and things. But I actually got really intensely into running, and I really had this thing about having a sub 20-minute 5K run. And so I was very lean and cardiovascularly very fit. And then I went from that, and all of a sudden I just ballooned out, and I looked literally like a balloon, with no change to my diet. I was always health conscious, not drinking much, not eating too badly. And it was water, and I was just suddenly had this water weight where I didn't know where this was coming from. And it was accompanied by quite intense headaches. And I spent around 9 months back and forth bouncing around certain GPs or primary care physicians, they call them in the States, with none of them offering to do any blood tests whatsoever, even though I asked for them. I felt very fatigued. I felt like no matter what I did, I just couldn't recover from exercise, even when I tried to. So I did what anybody would do that has any kind of medical background training, and I just started reading about what these what seemingly ambiguous symptoms could be. Because the edema was what worried me the most, because I worried about fluid maldistributive disorder and something to do with cardiac issues.
Absolutely.
So it was peripheral at first, but then it started sort of spreading more to my face and things, and people noticed. It's like people said, why does your head look like an orange? Was one comment I got. So I was like, you say to yourself that you were like, is it just me, or is it? And then when someone says that, you're like, oh, it's not me. That's just me. So I didn't know what I was looking for, so I utilized a private blood testing company, and I tested absolutely everything. So my prolactin came back high, and my testosterone came back low. So I had an MRI of my brain, which was organized very kindly by the GP, who initially didn't want to do anything with me. It showed its actual wording showed that raised parenchyma. So that's the spacing around your anterior pituitary, or the fluid around there. And it said, in keeping with blood results and high prolactinoma cannot be ruled out. However, this was upsetting. Contrast not utilized. Recommend redo with contrast. I never actually had the redo done. So I just went with the fact that it was obvious that there was something wrong there. I had top of the reference range gonadotropins, which I thought was probably secondary to my cryptorchidism. Testing that means to anybody else. And then that being not fixed for a bit. I just thought, that's probably what this is. So I reapproached my primary care physician for TRT, because I was like, my total is 7.1 nanomoles. My free is less than 0.2. So what can we do? And he said, well, you have a beard, so we don't need to do anything. Which was a little bit of a curveball to me. I was like, clearly you don't understand how the DHT cascade works during puberty. Obviously,
I've heard that before. I've heard that from other patients. Other primary care physicians have told that to patients I've worked with, and it's shocking to me. It's shocking.
Because it doesn't. It's not. Once you have been through puberty and your DHT cascade has occurred to allow you to have secondary sexual hair, like beard hair or pubic hair, it doesn't mean that if you've got low testosterone, it all falls out. That's not how it works.
Precisely.
So that was a little bit of an eye opener to me, to get a second opinion. And I got a second opinion from the same practice, but unfortunately, that GP was the trainee of the GP that I'd just spoken to. So he actually just parroted what they said. So that's when I started looking into private options, and I found a clinic that would help me. And I actually ended up working there for a brief period, which is where I learned quite a bit about that. Although I'd say most of my knowledge was gleaned from my personality type. So I'm the kind of person that if I don't know anything about something, I will find every academic paper out there, and I will drink it in. Like, not sleeping, I will use that time to be like, right, let me learn more about this. And I did that for a good couple of years whilst being started on treatment. And I got an exceptionally good understanding, in particular, of enzymatic processes, because I believe that they're really key into how all of this works. Because I just always found it so interesting how you can have two guys that look almost identical on the same dose, and one has very low levels and the other has very high levels. And we've talked about this before. These specific enzymes are very interesting, because it's not just as simple as this should be enough for you, go away. So I got into it through doing that, and then I got noticed for another clinic which asked me to be the lead for their whole HRT thing, to do females as well. that didn't work out, unfortunately. But it has led to something really nice, which you alluded to at the beginning, which is that I'm now the ACP working part-time for Dr. Angela Service at the Eden Clinic for Men in Plymouth. So hopefully,
that's exciting.
Hopefully we'll get to meet some of you. So yeah, in a nutshell, that's how I got there, and I know we all have our own journey of how, as healthcare professionals, we seem to end up in this sphere, and it's because we don't want people to go through what we went through. we want it to be done right, and I know you're the same. You have a very similar story, like and even down to your ER background as well.
It's shockingly similar. I won't take up time to go through it. Maybe I save that for another time. But yeah, bilateral cryptorchidism was either missed or ignored. It was repaired late. And, very similar experience down the road as I got older, where I just realized something was wrong. I didn't get the swelling, but I had the, what I consider to be the neurocognitive symptoms of low testosterone. And I was already a board certified physician at the time. So I was fortunate that I didn't have to go through that whole process of being dismissed by the established medical community, because I know I would have been, because at that point in my life, I was in my mid 30s. I had already set like state records in powerlifting, completely natural. I don't know what my testosterone levels were in my early 20s, but I imagine they were pretty good because I was able to perform athletically. I put on a lot of muscle tissue. I felt and functioned quite well. But then, I hit a wall at some point at about age 35. And I know that if I had walked into a primary care office without any sort of medical background, they would have looked at me, weighing 240 pounds and, lean and strong, and they would have automatically dismissed the possibility of a testosterone issue. And like you said, it's the same sort of thing with the beard issue. Once you've built a certain amount of muscle tissue, and as long as you're doing everything else correctly, you don't need a ton of testosterone to maintain it necessarily. Obviously, there is a certain threshold with that, but I had total testosterone levels that were right around 300, nanograms per deciliter, which was well below my threshold for symptoms. Yet I don't think anybody would have looked at me casually and said, "Wow, that guy looks like he probably has low testosterone."
Yeah, exactly.
But I did. I did. I was markedly low. So anyway, it's so interesting, and I'm the same way. As soon as that diagnosis was made, I was obsessed. I dove into it, and it was the remarkable life-changing benefits that I experienced with with testosterone therapy. Now have spilled over, changed the course of my career. Like you, I mean, I'm still in the mix in the emergency department and things like that. Now, I've taken, many, many years to learn as much as I possibly can about male hormones, optimization, very much into longevity, just like you are. And that's becoming increasingly a bigger part of my practice. So, getting, oh, sorry.
Yeah, I was just saying it has to be. We have to think about the
future. It has to be. It has to be.
And that's why training and TRT is something we're going to discuss today.
That's right. That's right. Exactly. So that leads in perfectly to, I think of healthy aging. There's three main pillars in my opinion, and I think you'll agree. I mean, the hormonal optimization is the sexy part, right? It's one that everybody's interested in. Obviously, testosterone. And then, right beneath that, guys are always wanting to know about growth hormone. And then there's obviously interest in thyroid too, but maybe a little bit less. But in my opinion, clearly we wouldn't be here talking about this if that was not extremely important. But the other two pillars, which are the nutrition, which we'll probably we should do another talk on that, is crucial. And then the training, specifically resistance training, which is what we're going to talk about today, is just one of the fundamental cornerstones of, in my opinion, if you want to age successfully, in this day and age, you better start, using your muscles to lift heavy things.
Yeah,
and that doesn't mean be a bodybuilder. In fact,
no,
I don't
exactly. It just
encourage
means,
that.
we don't, you hear people throw around phrases, like band around phrases like functional strength, and some of the people in the fitness industry are like, no, it's not a real thing. But I don't think that's what people who are saying that are meaning. They're meaning what we're talking about: being able to lift your shopping bags when you're 75, 80 years old, then being able to pick up your grandkids, being able to bend down and not throw your back out just by bending. Like, it's not having a kyphotic spine, like, or traditional hunchback, because you've lost all of that tension in your spinous erector muscles and in your shoulders. Like, it's it face pulls. That's something I just keep saying to everyone when they say, "Oh, my posture's like this," and I'm like, get on those face pulls, and you will get rid of that. Like,
you'll correct that.
I couldn't agree more with how important it is to lay on some lean muscle tissue as much as you can. Like you say, be below the age of 50, because after that, it's marginal gains, if any, and
Very
the
much
risk
so.
of injury is high. Like, it's So what's the best way to do that, I guess, is probably where we go next.
Exactly. Well, it's interesting that, you and I in the emergency room, I think probably more than any other medical specialty, I think it's in our face every single day, the consequences of ignoring muscle tissue or ignoring the development of muscle strength. And and now it's thankfully it's being recognized in the medical community, and it has its own medical term, sarcopenia, which is a pathological loss of muscle tissue. When I was in medical school in the late 90s, I don't recall ever hearing that word. Nobody talked about the importance of muscle tissue. And now it's only now, you and I have known this for decades, but it's gaining traction. Even mainstream physicians, endocrinologists, internists, family docs are realizing, muscle tissue is really important for metabolic health. It's one of the best ways to get control of somebody's hyperglycemia, right? Is to put on muscle tissue.
It is metabolically active.
It's actually better than metformin. It's better than any pharmaceutical agent. So it has major implications even acutely in the emergency department because of just simply elderly falls. The ability to, if you catch your toe on the rug, and the ability to plant your other foot in front of you, support your entire body weight for just a few seconds to keep you from falling, that it truly can mean the difference between life and death if you're an 80-year-old person.
Oh yeah,
and
that leads to a NOF or a neck of femur that people out there that don't understand the acronym.
Exactly.
And then once you get that, you're in hospital. The next thing that happens is you have a nosocomial or a hospital-acquired infection, and that will be pneumonia, and that's you done. Like, just because you tripped.
That's you start circling. We call it circling the drain. That's the first. That's the first event that it then brings you into the medical system, and you probably are not going to get out of that. At that point. Maybe you will, but
avoidable. But it's avoidable
100%
through
avoidable.
future-proofing yourself.
Exactly. I love that term. Future-proofing. That elderly 85-year-old, if they had began, looking into this and doing what they could to stave this off in their 30s and 40s, maybe, just maybe, that they wouldn't be in that situation. And I'm not faulting them or blaming, trying to blame the patient. It just, we didn't know this stuff, and it just wasn't. Weight training and this sort of thing just wasn't part of the culture when, certainly like in my parents' generation. In fact, I remember growing up, and my dad's quite a bit old. My dad was an older dad. He was in his 40s when I was born, and he was very much against me weight training initially. Oh, you'll get muscle bound, he said, and you'll stunt your growth. Were the two things he told me when I was about 16.
The stunt your growth one is such a popular one.
That's a popular one. And even that at age 15 or 16, I was like, Dad, I don't think that's true. And thank God I didn't listen to him. So anyway, it's but it is so important. It's so important. Sarcopenia is a major it's one of the root causes of many medical conditions, and it has ramifications in areas that you wouldn't even think. Again, like glucose metabolism and cognitive health. It's it's a bit controversial, but I would say that muscle tissue is probably the most health promoting tissue in the human body. And
for sure.
and arguably you cannot have too much muscle tissue in terms of your natural ability. Obviously, professional bodybuilders, you don't want to go down. It's the things that make them unhealthy are the things they do to get the muscle tissue, but it's not really the muscle tissue itself that is harming them necessarily. There might be, obviously with sleep apnea and issues like that, it could be an issue. But as far as within that normal human range, those guys are sort of superhuman. I would argue that muscle tissue is
they're on that side, aren't they? You've got a bell curve going way over there.
That's not normal physiology.
Yeah, the threshold past which accumulating lean mass or lean muscle tissue becomes harmful is when it becomes at a point that your skeleton was not designed to hold, and therefore your circulatory system starts to adapt to that, and that's when you get things like cardiac remodeling, for example. But one could also argue, that your cardiac remodeling was precipitated by some of the substances they're taking, such as nandrolone decanoate. Like that's a known one for that.
Exactly.
So and it's used a lot. So I think those sides of things, they're not a great example of saying, lean muscle tissue is healthy, because but I understand what you mean in terms of laying down the right amount of muscle tissue for you, so that even in the face of age-induced sarcopenia, you then just go back to normal size and can still function because you were well built before you got to that age. And you can even, if you're going to be on TRT forever, which some guys are, you can even maintain that as long as you do everything safely and you adapt your training.
You certainly can.
And that's the training as we get older.
Yeah, exactly. So actually, that's a great segue. I started off in the with weight training. I would say in my teens, I completely self-educated, which there was no resources back then. I mean, I just looked at muscle magazines, and I had the Arnold Schwarzenegger encyclopedia. And so I just sort of did what was there in those, which was not the best advice. I never had a coach. I really could have benefited
from Arnie. Everybody started with that.
Everybody does that stuff, right? And then I came from I briefly in a powerlifting background, which was both good and bad. I put a lot of stress on my joints, and again, I could have benefited from a coach, but as I've gotten older, that's my training has had. And my priorities have changed towards more function and health, but also preserving the amount. I probably peaked out in terms of muscle tissue honestly probably by about age 20, and then the rest of my life since that time has been trying to maintain that. And I don't think, honestly, for me, this is different than many men. I think I have not built a ton of muscle tissue since starting TRT. In fact, I've lost muscle tissue. But I know that I've lost far less than I would have being hypogonadal.
So, that's a given for sure.
And that's the true value, I think, of TRT past age 50 is that downward curve that you see in terms of muscle tissue, muscle strength that we're told is inevitable with aging. It really is possible to flatten that curve quite a bit.
You can't get rid of it completely, but you can certainly stay with that for sure with healthy hormone levels. And like for me, I was similar to you when in diagnosis. I was mid-30s, and I had all that water weight, and that all started getting balanced out when my estrogen was sorted and things. An insanely sensitive response to my TRT, and I had my cognitive effect almost in the first 8 weeks. I just really started feeling motivated again, and having trained for years before, I smashed it in the shed gym that I had, and I properly transformed my physique, and I gained a lot of lean muscle tissue. So I've got a before and after picture somewhere, but just to remind me that when you have healthy hormone levels, what's possible with hard work. Because at no point did my testosterone levels go super physiological. They just went better. They were more than 7.1 nanomoles per liter. So I took advantage of that window of feeling better. And over the next 3 years, I trained consistently, and I probably didn't do it the right way looking back, and especially if we're going to talk about what we talk about tonight. But I was training like 6-7 days a week. Like I was just, I had a home gym, and I was just smashing it every day. I would get up at 4 a.m. because I had to be on shift at 8 a.m. and I would train after coming back from shift. And I really wanted to maximize that first sort of year where you're on TRT, where there is potential to make differences. Now, not everybody responds like that, but I did. I do have a picture somewhere. I haven't got it on here. It would have been interesting to share it, where I show what I look like in my runner's physique, where I was into running just before I figured I had low levels, and then what I look like when I am doing weights. So yeah, it was really, really interesting.
Yeah, it is. It can be absolutely remarkable. But you said something really important there. Is it was putting in the work and the effort with the hormones, because we both know what happens if you optimize hormones, but then don't adjust the other two parts of that equation, which is the nutrition and the training. The results are really suboptimal. And just not good. Like if at all, right? Yeah. I tell guys you might get a little bit of the cognitive clarity and things like that but don't expect, and that's a big thing with TRT, obviously, is expectation management. Is listen, you're not going to wake up with a 6-pack unless you do the things that you need to do to get a 6-pack. So
exactly. It will just hopefully clear those cognitive issues that allow you to have the motivation to go and do what you need to do. Like, because it's not, and nothing is given to us in life. You know, when you got yourself into that situation of metabolic syndrome where you're very overweight, you've basically been taking and taking and taking for a long time, and there will be reasons for that, which probably require some CBT to talk through. There will be reasons behind that, because I've never met a guy that's very big that hasn't got trauma in his past, and that needs to be accounted for. So as part of your treatment process, so you can't just go, here's the testosterone and plus minus other any ancillaries, and not address the mental side of this, because a lot of these guys are hurting, right? But what they've been doing is they've been taking and taking, and that's been manifested in food, because they want the dopamine hit because it makes them feel good. And that's how they know how to get dopamine. And the thought of putting the food down, losing that one bit of the day where they felt good, is really scary. But then on top of that, you saying you're not having that kind of food, you're going to have this kind of food, and you're going to go and beast yourself in the gym. It has to be graduated when you see these guys. We can't hit them with all that information at the beginning. And you mentioned it very succinctly. Management of expectations has to be graduated, because you can say you will get to this goal, but it's going to take a year, 2 years, but you'll only get there with guidance from me, guidance from other people that will tell that, to help psychologists, psychotherapists, and personal trainers, and sometimes nutritionists, dietitians, because some people genuinely don't know how to cook. They don't know how to eat. So they exactly. You say, "Oh, just eat more cruciferous vegetables," and they're like, "What are those?" Like,
what is that?
Know, right? Yeah. So it's about the full package, and it being a complete continuum, and making sure that our patients know that just being on TRT and losing weight is not the key to being the best version of you that you can be, for sure.
Exactly. And that's, and of course, many of these men come to this space through social media. And so they, social media obviously does not preach that message whatsoever. There are all these influence. They look at all these sort of guys on TRT and that are, just in that space. And one, they don't realize that many of these guys are taking PEDs. I mean, quite honestly, the fitness influencers and whatnot, and then very, very few outside of the medical space, like that you and I are in, are talking about trauma, are talking about unpacking. How did you get here? How did you get from where you? Well, how did you get to where you are currently? And it's not entirely because you just have low testosterone.
No, exactly.
There's
key,
other issues there. Yes.
It's separating them out. Like, it's a part of it, but it's a confounding factor among many. But yeah, and then, once you rebalance that part of it and perhaps address the other psychological issues through talking therapy, then we get to talk about resistance training. I think it's probably the best form of training for any guy who's on TRT. You can do others if you want, but you don't have to lift weights. But this sort of ethos of putting on lean mass in order to preserve or future-proof yourself for your health later is well documented. And it's what we want to talk about today. So how do we do that?
Well, that's a good transition point too, because I know your answer to this because we've talked about it before. But when a man comes in who's very, very overweight, but who also has obesity-related sarcopenia, which is a thing. A lot of people don't realize that. They assume that if you're carrying around a lot of excess body fat, then you must also have a fair amount of muscle tissue, right, to carry that extra weight. But we both know that's not true. That like visceral body fat is actually directly toxic to muscle tissue and through a variety of mechanisms. So these men, they have high visceral and subcutaneous body fat, but then they also have a very relatively low amount of somewhat dysfunctional muscle tissue. So it's the eternal question, right, that we talk about all the time is, what do you do first? Do you get the work on getting the fat off first, or do you work on building the muscle tissue? Because everybody wants to do both. And ultimately you do want to reach a state where you have accomplished both. But how do you approach that? What's your general philosophy to that?
So these patients come under a class of patient called MOSH, or if they are neither primary nor secondary or tertiary, involving the prolactinomas types of hypergonadism, they come under MOSH, which is male obesity secondary hypergonadism. And what that means is they have forced their testosterone levels low by becoming obese. And that's because subcutaneous and visceral fat tissue is a substrate for an enzyme called aromatase. Now, aromatase will convert our testosterone into estrogen. So you've got your liver doing that, which it should do. That synthesizes that enzyme. But then when you've got all these fat cells, you've got millions of factories also synthesizing that enzyme, which they shouldn't be doing. And that's what forces your testosterone down low, because it's over-converted, and then you end up with high estrogen. So these guys, you often see it with very high estrogens for men, which in and of itself isn't an issue, but it's the correspondingly very low squash testosterone that makes them have those symptoms where I just can't get out of bed, I can't do anything. The only way I feel good is by eating, and they eat the wrong things, like sugary things, fat-containing things, because that really stuck in that washing machine. So what do we do with them? So for me, when I get these guys, you've got to be cognizant of the fact that they, like I said before, they didn't want to be like this. That wasn't their goal. Something has happened that made them get like this. So it's unpacking that. Now, once you've unpacked the reason as to why they eat so much or have eaten so much to this point, but they're in front of you and seeing you, and that's amazing because they want to change. That's why they're here. So what do we do for them? Is it best, it's the age-old question, is it best to cut or bulk first? Because you've got this situation where they've got very little muscle underneath all that fat. So you want to develop muscle in order to allow that muscle to help them be able to move more easily. And also muscle takes calories just to stay on the bone. So that burns fat. But there's so much fat on top of that non-functional muscle that it makes it hard for them to move. So where do you begin? So for me, it's about looking at what they can do first and what they are doing. So first of all, you look at functionality. Like, are they able to go up and down the stairs? Like, has it got to that point where they can't go up and down the stairs? Are they sleeping downstairs? Now, if they're at that point, that's rock bottom. So what you start with there is saying you can, because they always say, I can't exercise. And then I say, you can exercise because you can get up to go to the toilet. And they're like, yeah, of course I can. And I'm like, well, when you get up off the sofa, you will start by pushing up with two hands, because these are big guys. And then the next one, you'll start by pushing up with one hand. And instead of going to the toilet, just do that 5 times. Now, when you see a guy that big, you're essentially doing a squat, like, because the couches are very low, aren't they, traditionally? So you're getting up and sitting down involves your core, it involves your quads. Now that's how you can start with these guys, because a lot of them will say they cannot do any exercise because of how much their knees hurts because of the weight that they're carrying around, but they can move. Like, so if you can start with low level things, and this is where having a dedicated personal trainer really helps, because they can go to their home and look at what they can do just going around the house and they can make it into exercises. Now I've seen this work where one guy was just 300 pounds, like, and he was sleeping downstairs. He had everything bought downstairs for him. He would order in takeout, he would always leave the door open so that somebody could come in to give it to him, which is dangerous in and of itself. And he wouldn't even get up. They would just deliver him his KFC, his like Kentucky Fried Chicken bucket, family bucket just for him, and he'd sit and eat that. That was like a snack. That was a snack for him. And it started with, full input from dietetics, so dietitians, personal trainer. Personal trainer went to his house, talked about what I've just said. Just get up and then sit back down again, but don't lie down. Like, it's like sit upright, so keep yourself up. Because this guy would sit down and then immediately put his feet up. And he's like, right, we're not doing that anymore. We're going to be seated. And they changed the couch for a chair so you can't lie down. And so he had to get up and sit down, and was essentially doing body weight squats throughout the day. And then they gradually increased that. And it got him to a point where he was able to actually go to the stairs, which was the first time he'd done it in apparently like 3 years. And then he walked up the stairs. I mean, according to my friend, the PT, he said it looked like it nearly killed him. Like, just, can you imagine being in that state where you walk up your stairs and you're out of breath? Like, then after that, he obviously was upstairs and he wanted to go back down. So he had to go back down. And then that became part of the daily exercise routine. He didn't need anything from upstairs, but he went up and down the stairs. And this guy shed so much weight, like in a month, because he's not ever been moving. So when you get to a point where you're that big, any activity is considered extra by your body, and you start to lose weight. But that got him to a point where he lost quite a significant amount of subcutaneous fat, to where he could go for walks, and then the walks eventually, gradually over time, build into jogs, and then the jogs built into runs, and that's when they managed to get weight training implemented. So it was a long journey for that guy. I think it was like 6 years.
But that's okay. That's fine. Okay. If that's what it takes. If that's what it takes.
So he was 36. He's got a long life.
There's no time like the present.
And he was one of my patients that I was really proud of, because he actually lost so much weight, and he was very tall as well. That was the other thing. And but the only problem he has now, and still to this day, is extra skin, because that obviously needs to be removed. But that's not an issue. Like, that can be sorted at another time. But what he does have now is healthy hormone levels and a good amount. He has a really good. He's got big arms. Like, he's got a good amount of skeletal mass. He's good at pull-ups. Like, he can do actual overhand thumbless grip pull-ups, which a lot of people can't do one of. Like, and he does them weighted. So, for a tall guy that used to be that big, that's actually a massive achievement to achieve the back and shoulder stability. So that, for me, it's got to be incremental. When you're presented with these guys, it's got to be incremental, and you have to be realistic with them. You're not going to lose this in a year. Like, this is going to take time. And you have to tell them that the testosterone will help, but it isn't magic. It's not a panacea. So, because like you said, a lot of people, they'll take testosterone replacement therapy, which we must remember is replacement therapy of a deficient level. We're just normalizing it, but probably to the slightly higher end of the high level. But it's still classed as normal. It's not super physiological. So of course you're not going to wake up tomorrow with a six pack. It's just not going to happen.
That would be nice.
You have to put the work in, and the work comes from exercise and from diet, and it's it's that triad of hormonal health, nutrition, and exercise that will get you the results that you need. And
I love that story. And there need to be more stories like that out there, because unfortunately that poor guy, when he logs into Facebook or to Instagram, he's going to see, all the people that we just talked about. And even just guys like us, who are, who are not, these, ultra ripped influencers and whatnot. But, like, I've been working out for 35 years. Like, this I look at the way I do at age 50 for 35 years of work and dedication to it. And so a guy like that, who's that far, say, on the left side of the bell curve of fitness, he may just, it's so easy to just throw your hands up and say,
yeah,
forget, like, there's just no
I'm
way that
done.
I can
Yeah,
do that.
yeah,
And what I would say is, I'm sure what you feel the same way is, well, listen, you don't have to be me. You don't, in fact,
yeah,
you don't want to
exactly.
be me.
Yeah,
Like,
yeah,
there are sacrifices that you make to reach, certain levels of fitness, but you don't have to. Do not compare yourself to other people. You
yeah,
are you. And
yeah,
that's where this, as clinicians too, we have to make individualized programs for people. And these
exactly.
cookie cutter
Tailored care.
recommendations are not, they're not going to be beneficial for a man like that.
Yeah,
To have him say, well, go to the gym and just start, just start doing squats,
yeah,
or
yeah,
get on that leg press machine. That
yeah, yeah.
barrier to entry is way too
Oh
high
yeah,
for him.
yeah, yeah. I mean,
um,
and I've heard other clinicians out there just go, "I've sorted your hormones. You need to do the work." It's like it isn't
right.
that simple with these people
It's
that are
not,
that far gone. They
not in that
need
case.
help. Like, yeah,
Yeah.
no, exactly.
No.
Yeah,
Yeah.
it's so much more layered than that. Like, to say go to the gym
Mhm.
to someone who's really big that hasn't been
Mhm.
outside for years, that must be the scariest thing ever to walk in
Oh,
there and just
absolutely.
be
Yeah,
like, yeah,
absolutely.
and say to someone, "How does this
Mhm.
machine work?" That might actually make them have a panic attack. Like, it's just,
No,
it isn't
absolutely.
as
Yeah.
simple as just
Yeah,
doing the work.
absolutely.
You know,
Yeah.
we
Well,
all need to
fortunately,
earn our things, but like we need to have the methodologies to do it as well.
yeah. So guys like that are, they're not super common, but they're certainly out there. And, obviously they have huge barriers to entry, but our average person, hasn't, maybe he's not quite that far down the path to poor health. But one of, the most frequent thing that I hear is I don't have time to exercise. I
Right.
don't have time to
Yeah.
go to the gym.
Yeah.
So I have some sort of stock replies to that.
Yeah.
How do you approach that question,
Yeah.
or
So
for that,
my
initial thing? I don't have time to
yeah,
go to the gym or
it's
to weight
very,
train.
very common, isn't it? You hear that
Yeah,
all the
yeah.
time. But yeah, I have my stock response is actually one borrowed from a personal trainer. He's a friend of mine, very good friend of mine, actually, for the last 12, 13 years.
Mhm.
Very good trainer, James Lambert Personal Training for anyone out there in the UK. Yeah, he said everyone's got an hour. Like, and I thought to myself, actually, yeah, everyone does have an hour because all you'd have to
Sure.
do is wake up 1 hour earlier and you've got one more hour.
Mhm.
Like, so
Mhm.
what that then begs the question is do you value sleep more than you value your health? Now, you
Mhm.
can argue the minutiae that we need sleep to be healthy, but
Yeah.
if you're getting a decent level of sleep that can allow 1 hour less but still be good and healthy,
Mhm.
that hour could be spent exercising. Now, that's what creates a mindset, and then
Mhm.
it's all about your routine and your discipline when it comes to this, because everybody's motivated at the beginning. When you're doing something and it's new and it's novel and exciting, you're like, yeah, I'm in this. That lasts for about and there's literature on this, for about 90 days max, like, so
Right.
12 weeks. So, and then
Right.
when you stop seeing amazing results, you start going, oh, why am I doing this? Like, but what it
Mhm.
then needs to become is part of your identity. Like, it needs to be, I do
Precisely.
this because this is what I do. I get up at
Mhm.
5 instead of 6 because I go on the bike in the gym, and
Mhm.
that makes me feel good and it sets me up for
Yeah.
the day. But at the same time, in the back of your mind, that's setting your heart health for the rest of your life.
Mhm.
You could get up an hour earlier and you could lift weights in the gym, and it's hard doing that fasted because it's some people can't, just feel like that's something they can't do, but it is definitely doable. You do get used to it,
Mhm.
but it is
Mhm.
setting you up for cardiovascular health and musculoskeletal health in the future. So it
Mhm.
has to be about routine and discipline rather than motivation. Motivation is great if you've got a little
Yeah.
goal you want to get to, but
Mhm.
when it comes to health, it's an everyday thing. We need to be thinking,
Mhm.
when I'm
Mhm.
75, I want to be able to pick up my grandchildren. That only
Mhm.
comes by planning now, by doing that future proofing.
Precisely. Yeah,
Yeah.
exactly. Yeah, I feel the exact same way about it. We all have the same 24 hours in a day,
Mhm.
and I get it. It is hard. You and I have both been through very rigorous medical training programs. I, routinely would work over 100 hours in a week
Yeah.
during certain
Nights
times
into
in
days.
night shifts. Yeah, the swing shifts are murder.
Yeah.
And trust me, I get it. It's hard. Even now, like, I have a 1 year old now at age
Yeah.
50. He does not sleep well
Yeah.
at all. Although we're getting there. it is hard, but you have to just make it like you are spot on. Like it is part of your identity. It's just what I do. That just has to be like, you have to internalize this notion that you are an athlete. Just because you're not out competing necessarily, you're still an athlete. Your body was meant to do this in some capacity. I mean, that's just how it is. So
when you say that, like it's spot on. Like, because if you go back to how we evolved as human beings, we were way back in the Neanderthal days. We didn't have superstores with our food being provided to us and a fridge in our house. We had to go and find it, didn't we?
Kill something.
Yeah, we had to
something bigger than us.
Something. So we had to use muscle and tools, and we had to run. so we had muscular strength, and we had cardiovascular fitness because we had to find our food. Like it's
you're built to do this. You know, this is something your body is designed to do. It's not designed to sit on the couch.
No, exactly, and it's built to be active. And like, and then, you know, then we get back to the sort of, you know, people say, you know, occasionally you'll get that response, I don't even have an hour. Then you need to think about what are the most effective training methods to allow this person to be able to get something done. Like, and you know, and then you've got to split into your groups of, are they someone who knows how to lift already, or are they a complete newbie who needs some other kind of direction? And then you've got to think about cost. Where can they afford a personal trainer? And we can go into all of that. But I know you've done a great video about your medical training where you were trying to get in some training and you managed to develop your own 30-minute thing. And I mean, that's the dedication to the identity of what you do, isn't it? It's like, I know I'm a doctor and I've got to do these exams, but I'm still training. And that's when it becomes about discipline. So, you know, what is the best then? Like, well, there's a few studies that look at how to maximize things, but you've got to think about, you know, what your goal is. So there's one study in particular, which I'll pull up on the screen now, about maximizing muscle hypertrophy. And that's here it is. And that's actually really good because it's a systematic review. Let me just share it on the screen. Let's bring it up onto the stage. There we go. Yeah. So this one is a study that is a systematic review. So for those that don't know what systematic reviews are, that's actually one of the highest levels of evidence you can have, because it's basically where a team of people have looked or have pulled all of the studies on a specific subject, and then they've brought them all together to assess them for their scientific quality. So then there's very strict and stringent criteria as to how this is done. You know, if you want to learn more about that, then I'll recommend something probably towards the end of this that we can look at as well. But essentially, this one was looking at maximizing muscle hypertrophy. So it looked at a systematic review of advanced resistance training techniques and methods. So the thing is with these studies, with most of them, they looked at already trained males. Okay, so when you look cross-sectionally at that, you could argue that it's transferability to general population of patients we might be discussing or seeing routinely is not great, because we generally tend to see people who are not already in the gym and they've got to a point where we're needing to explain how to do things like this. So that's I guess a flaw in this, in that they picked mostly trained males. And then they looked at what sort of the best rep ranges, what sort of the best weights to lift. And this is just showing you the criteria here as to how they included eligible studies in order to critique them all. But essentially, what they found out of this, I'll scroll right to the results at the bottom. There's a summary up the top here. But essentially, they aimed to look at muscle hypertrophy and finding what's best. So by that, we mean putting on muscle, like putting on lean tissue. They obviously found other factors as well and other results. But in terms of looking at high load versus low load, and then high reps versus low reps, it came together with what most people found. And now they've said that there was insufficient evidence for specific guides for volume, so how much weight to lift, or intensity of effort, because that's very hard to try and generalize for, because everybody's input is very different. You can only use something called electromyography, where you can measure how much the muscle is tensing and how much load it's taking, which is different for everyone. But the thing they found was frequency. Okay, so what they found was that if you're a well-trained athlete, they integrated these advanced techniques, which were, doing drop sets, supersets, reducing your rest time, so essentially increasing volume without actually adding more plates. Blood flow restriction was another one that they looked at, which is an interesting area of training, where you actually tourniquet a certain muscle group so that you just train with the blood that's in that muscle group rather than allowing recirculating, reoxygenated blood into it. They found that these advanced techniques allowed people to break through plateaus. Now, again, these are plateaus for already trained males, but it was interesting in the fact that throughout all of them, they not only increased the building of muscle tissue, but everybody, regardless of what rep range they used, increased in their strength as well. But then they did notice the trends that people that use low load and minimal reps, they actually gained more strength. And the hypothesis for that was that they had more frequent training of their CNS, their central nervous system, to take or expect that kind of shock. So, which is seen in the powerlifting community, which I'm sure you'll agree, Andrew, you've seen before as well.
That's precisely true.
That was an interesting one. And it's actually sort of parodied by other ones that people will go out there and they'll say, "Oh, well, I saw this though," and one that sort of springs to mind is this one, which I'll try and share just now, which I found really, really interesting, and it's called the 3-7 method. So let me just try and share that for you. So let me screen, so stop that one and then start this one. Yes, and the 3-7 method is really interesting because this is looking at time efficiency, which circles back around to what we were talking about. So it's basically a study that looked at a bunch of guys who were instead of doing your traditional 6 to 8 rep or an 8 times 6 method, which is a standard hypertrophy rep range, 8 reps for 6 sets. They looked at a new method, which they called the 3-7 method, which consisted of 5 sets of an increasing number of repetitions starting at 3 and ending with 7. So what you had to do was you had to be able to pick a weight that seemed very easy at 3 reps, but seemed almost impossible, as into failure, at 7. And now the kicker to this was that you were only allowed to rest in between your reps, in between your sets for 15 seconds. So you got muscle fatigue very quickly in a short space of time. And it took a 90-minute workout, a traditional 90-minute workout, and it squeezed it into 30 minutes.
Perfect.
Now, which is perfect. So while still hitting the same volume. So that's this one, I think, was specifically looked at elbow flexion, and the measurement for the control was the 70% of 1 rep max of a bicep curl. But it can be generalized to other workouts. But again, it looked at trained males. But what I thought was interesting was that the 3-7 method actually provided a better stimulus for strength gain and muscle hypertrophy than the regular, more accepted 8x6 method.
Right.
So there are ways. Yeah, there are ways that you can actually get these things into your patients' days that say they don't have any time. So it's sorry, I didn't have that scroll. They're scrolling through and I didn't show you, but it's an interesting study. There's the DOI number for anybody that wanted to have a look at it, and the abstract and the conclusion. But it's something that I have actually been employing because I'm a bit sort of time poor at the moment, and it really make you sweat. Yeah, it's something that's really hardcore because a 15-second rest is gone in a flash, and then you picked a weight that is going to get you to failure on that last set, and it's only 7 reps. And psychologically, you say to yourself, "I can do 7 reps, no worries." But try doing it 3, 4, 5, 6, 7 of a weight that you know that you'll fail with at rep 7, and see what happens.
Absolutely,
it's a really interesting study.
I really like that. That's I might have to try that actually. That specific workout
you watch
myself.
What happens, because you think to yourself, and what will happen to you is what happened to me. I picked a weight to begin with. I was like, easily do that, and it was far too heavy.
Way too heavy. Yeah. You have to put your ego in check for stuff like that.
Because I quickly found out once I got to once I got to 5 reps, I was like, I'm never going to be able to do 6 and 7 with this because I'm failing already. So yeah, you have to.
But people assume that in order to build even a decent physique, that you do have to be in the gym 5 days a week, 6 days a week for 2 hours.
Yeah.
And again, that's probably from social media, but it really is not true. Granted, like if you want to be a professional bodybuilder, okay, fine. But that's your job. That is your job. But you can get fabulous results doing a system like that 3 days a week for 30 minutes. And I would argue that almost everybody can squeeze out, 3 days a week, can squeeze out 90 minutes. And even if you do it twice a week, I would argue, you could split the body in half, or you could do 2 full body workouts like the old Nautilus system. And the vast, you're still going to reap tons of benefit from that. It absolutely can be done. It absolutely can be done. My current workout right now is a Monday, Wednesday, Friday split, and it is roughly 30 minutes. It's a little longer on leg day just because I have to. My warm ups are longer on legs. I'm getting old and arthritic, so I have to like warm up a little. But that's just because the actual training itself is it is 30 minutes. But as you alluded to, the training intensity is quite high. This is not a casual workout. I put my headphones in, I put on some angry music, and I don't talk to anybody, and I just get it done. But it is when I tell people that, they're genuinely surprised many times, because there's just an assumption that you have to do this hours and hours a day, multiple times a week. It's not true.
Which is insane. Like, there's other studies out there like this one right here that this looked at the shortest amount of time you could to work out, and they went with 13-minute sessions. Like, so
perfect.
So
I believe that.
And it's over an 8-week period, and they marked that the muscle hypertrophy gains were similar to those with a greater, substantially greater time commitment, as you can see right on the screen there. So your idea about the thing that reminded me of this one was the intensity. Like, so if you go in for 2 hours and mess about just doing rep ranges and weights that don't really push you, then you're not going to get anywhere. Whereas you can go in for 13 minutes and with an RPE, or a rate of perceived exertion of 10 on all your reps, and you will get a lot more progress than someone who just does the RPEs of 5. Like, it's
absolutely.
It's this can be, these kinds of things, I guess, can be quite sort of daunting to people that have never been in the gym, which is why you have to take this sort of holistic approach. But this paper in particular that we're talking about was actually by our good friend Brad Schoenfeld and Brett Concheras.
He's great.
There's not really anyone that's done more work than him on this type of thing. So it was a very good study. Albeit it's hard, I think, for when you look at these things, to allow for variability and confounding factors, because we're all very different shaped humans with different amounts of muscle, different amounts of experience, and different anthropometry as well. Like, some of us don't fit in machines the way that other people fit in machines, which is probably another thing as well to talk about. Like, is free weights
perfect segue? What are your thoughts on that? I mean, I see a lot of free weights there in the background. How do you have a preference, or what is your what are your feelings on that eternal debate?
I find myself as I get older, so I'm 41 now. Before, it was all about deadlift, squat, and bench, like the classic. and now I don't actually care about those anymore, and I find myself doing a lot more machine work movement. So I've got the primal strength leg extension and hamstring curl dual machine over there, and I do a lot of my lower leg stuff on that and my quads on that. And if I'm going to squats, I will use the hack squat, because it allows me to do squat beltless, but feeling like I've got the core stability of doing belted free weight squats without the wobble, and it's all in one motion. That if I feel like I've got a ditch, I can just pull the safety bars around and I'm done. And I do a lot of my other leg work when I flip it round, because that's dual combination as well. I can flip it into a leg press as well. And I actually managed to max out the amount of weight it would take. So I got something from there's a great person, I don't know if you've seen him, gympin.co.uk, and they make extenders to put in the out of it so you can put more plates on, which is so. And I needed to put more plates on, and I was like, how am I going to do this? And then I found out about him. So yeah, you should check him out.
I will check it out.
Getting a good PB recently, and I did 3 sets of 12 on the leg press at 308 kilos.
Nice.
So you know, when I got off, I looked like I was going to pass out, and I nearly did. But you know, the point I'm making is I have moved more towards machines, and I do still do the occasional days where I do deadlift. Let's see if I can still do this. But deadlift, to me, you know, especially when you get to the higher weights, because I only ever used to deadlift about 150 kilos for like 3 sets of 10 at 78 kilos body weight, which I was fairly happy with. But it's more of an ego lift, because it's not one that's really required to exercise what you're trying to exercise. It's a great posterior chain exercise, but there are other things you can do that are safer. Like, so, you know, I think, you know, to answer your question, I have gravitated. I do have a lot of free weight stuff here, and I still do military overhead press, because I really enjoy that. And I do weighted body weight pull-ups. Like, that's my thing. Like, you know, I'm currently stuck on 25 kilograms hanging around my waist whilst I do, you know, 3 sets of 10 wide grip overhand grip pull-ups. Like, because that to me, one of my strongest areas is my back. So I you know, when I'm not feeling great, I concentrate on strong areas because it makes me feel better. Like we all do. So yeah, it's a simultaneous love-hate relationship with those pull-ups. But yeah, I do get a great sense of satisfaction.
I love it. Well, I take a very similar. You know, I started off, you know, exclusively doing free weights. And a lot of that, obviously, because I was training for powerlifting, you don't really have an option to use machines in a powerlifting competition, but it is, you know, as the years have gone on, I've developed a lot of orthopedic issues, rotator cuff tears, and I've had surgeries and spinal fusions and things like that. So my workout now is exclusively machine based. And I do that mainly for the safety factor, because I train by myself, but I still train. I try to train as close as I can to failure. And you know, I tell guys, especially in their 40s, all it takes is one wobble, as you alluded to, on a squat or you know, on a fly machine, you know, as you take with the dumbbells, and then you know, now you're in the orthopedist's office and getting a rotator cuff reconstruction that takes you out of the gym for 8 months. So for me, you know, and especially after 40, and really and absolutely after 50, you just can't afford to suffer those kind of catastrophic setbacks, because the tissue that you lose when you're 20 years old and you have a catastrophic injury, you'll come back from that. You will regain, you know, the odds are you will regain whatever you lost. I had a full left rotator cuff reconstruction when I was 39, I think 39 or 40. And it took me an entire year of dedicated work to equal out the military press strength on both sides. And that, you know, at age 40. So I don't ever want to go through that again. So I'm extra cautious, and I still do jujitsu, which is how it happened. And I won't give that up, but that's just for personal, that's just because I love it. So I'm willing to take the risk in jujitsu, but I don't really see a need to take any additional risk in the gym when I know that I can achieve the strength and hypertrophy goals that I have for myself with a machine in a safer environment. So if I dump the weight, you know, it stays within a safe plane of movement, and I don't have to really worry. Now, certainly you can hurt yourself on machines. There's no question about that.
For sure. Like,
you know, but that safety factor is nice. So
and there's other benefits for cable machines as well. Like,
sure.
So, like, say for example, I'm a big fan of if you're going to do, say for example, lateral delt. Like, if you hold onto the frame and you set it down low and then you pull out like this through your legs,
it's fantastic.
That range of motion, getting the tension on the way down, which you don't get using a dumbbell, because you will just swing it down with the dumbbell. You have to control it down. that eccentric motion you get through cable machines actually
the constant tension.
Strength. Yeah. It's that time under
that's
tension.
part of my shoulder workout.
On
a routine basis.
I do it every single time.
Absolutely.
But, no, it's machines are very useful, and people, there's always been you hear that on like bodybuilding shows that it's like you can't get big on machines. It's like, yes, you can. Like you actually can, because whatever you're doing,
I think you
as long as you're progressively overloading, and that's the key.
Precisely.
You've got to progressively overload. Going to the gym and lifting the same weights every week and saying you feel good, you might feel good, but you're not progressing. So if you want to put that muscle on your frame before 50, which is so important, like watch Andrew's other video about that if you haven't seen it already. You need to add weight each time. Like, you need to progressively overload. You don't necessarily need to add weight, but you've got to progressively overload.
You go in and it's very simple. You initiate the stimulus, and then you get out of the gym and you allow recovery, and then you do it again. And rinse and repeat, right? Over and over again. Exactly. It never ends. It never ends.
And if you're, it's probably worth touching on, like, so we band about a lot of phrases like progressive overload and RPEs and stuff. We probably see patients, and you will have seen patients where they just haven't got a clue like how to lift, but they say they want to. Now, so what do we do with those guys? Like, it's, you've got to manage expectations so that they don't get injured. They might be
the injury thing is really important. You and I have talked about that before. It's especially with a true novice, the last thing you want them to do, the novice that's full of enthusiasm, and they get in there and maybe perhaps they get some bad advice from a gym bro. And then a month into their program, now they've suffered a catastrophic injury that kicks them out of the gym for 6 weeks to 6 months. It's it's extremely disheartening for them, but they also may not come back.
Exactly.
They might just say, this is not for me. Maybe they're embarrassed or something.
Sometimes that first impression can last forever.
So it's difficult. I mean, I would love to be able to train with all of my patients, but with the medicine platform,
it's not really with you, Andrew.
possible. So we will one day. We'll do it.
One day that'd be great.
So you have to be able to. You hopefully can refer them to a trainer who understands all the things that we've been talking about today, and can give them good advice and good guidance.
And, there's no substitute for that. I don't think there's no substitute for a personal trainer, a man or a woman next to you who knows what they're talking about, understands kinesiology, like how the body works, the anthropometric differences of people. Because the worst thing one thing I hate seeing is someone using a setup for a squat for someone who's like 6'8", and you're like, no, you do have to adapt it for them, like their hips are not where they need to be because they're so big,
right?
And then there's no substitute for that. There's no substitute for that. But then if you've got people that can't afford things like that, then I usually recommend things like this, which I'll just add onto the screen now. Like, so you've got things like nowadays there's an abundance of apps out there, that will guide us through this. Now, this one in particular I find particularly useful because it's affordable. Like, it's only like £100 a year, and then they have sales all the time, like Black Friday and things where it makes it super discounted. But the key thing about it is you don't have to know anything about food or lifting, and it asks you a bunch of questions when you register, asks you what you're allergic to food-wise, and it will say, what is your goal, what's your current weight, and then it will make weekly shopping lists for you and meals per day.
That's amazing.
It's incredible. And then it creates a training plan for you that will tell you how to progressively overload. And if you don't know how to do an exercise, you just hit the info button, and it's the guy that made it. His name's Matt Morcia, hence the Morcia logo. He's on video showing you how to do it. Like, it's absolutely incredible. So I don't think I've met many apps that are so all encompassing for a person who's never lifted before. It's it's something that I would highly recommend if you can't afford a personal trainer, or it's not a personal trainer is not your thing, you don't respond well to someone going, do it, it's like some people don't, then yeah, I'd recommend and apps like this, and this one in particular is very, very good. And I've tried
to check that out.
A lot of those apps.
Check it out. The other one that that I think is pretty good too, Renaissance Periodization, which is Mike Israel's company. He has there's a nutrition app, and then there's also a training app. And I've never used the training app, but it looks sort of similar in that it will take you through. It's a periodized approach that you can build in a program based on your goals. The nutrition app is pretty good. I've actually played around with that a little bit and used it. I'm not sponsored by them.
I'm not sponsored by Morsha Limited, by the way.
But the point is that there are people out there who have built these platforms and these resources that are reasonably priced, and it's worth the money. It's worth the money just to get the education, because this is something you'll use probably for the rest of your life. Even if you don't use the app, you'll use the knowledge.
Yeah, and that's the thing. Even if you paid £100 for that app that we just looked at, and then you solidly did it for a year and you completed the programs, and the cool thing is it will remind you to do stuff as well. It's like you haven't checked in with your training today. And even if you use that for a year and then you've got it in your head and you don't pay for another year's subscription, you've still got that in your head for forever. Like, you know how to train now, like you didn't know how to train before. So,
and then you can go and help someone else.
Exactly. Exactly. And you can pay it forwards, can't you? Yeah.
Pay it forwards.
And that's what I think we need more of in life, because it's nowadays. I mean, like I said to you previously, I don't have this problem in a home gym now, because I train whenever I want and by myself or with my kids usually.
That's nice.
Worrying about their fingers on the weight plates, but but like I don't have to wait for equipment anymore. But a worry for people going to gyms where they don't have the luxury of a home gym is like having to ask someone, how do I do this exercise? So apps like that are absolutely brilliant, because they can just have a quick look at the video whilst they're waiting for the guy to finish, or the girl to finish on the squat rack, for example, and go, right, this is what I need to do. And it takes that layer of anxiety out of fitness for them. But
absolutely.
There's so many, there's almost no excuses nowadays to saying I can't do it. With all these apps, you can put a week, and it will even design you a 1 day a week workout where it will hit all muscle groups. I mean, that's an intense full body workout. But you can tailor it to your work schedule, everything. And the one thing I like about that app is the menu thing, where it knows what you're allergic to, so when it'll adapt the recipes that it's suggesting. And you put in whether you want to gain weight or lose fat, and it will reduce your calories incrementally each week based on your weigh-ins, because there's so much out there. And it's like having a personal trainer in your pocket if you can afford a personal trainer. So it would
have been nice to have all this stuff when we were first starting out.
Can you imagine? Like we're just reading magazines or asking the biggest bloke in the gym, how did you do this?
Right. And that's I can imagine I could have saved so much time. And I probably could have avoided a lot of the injuries that I had just by having access to good information that just wasn't around in the 90s. It wasn't available.
Access to that was Ronnie Coleman. That's my ringtone.
Nice. Poor Ronnie.
Bless him. So on the thing about information being accessible, yes, it's out there, but it's about knowing what the good information is. And that's where we were talking about. Now. Like we're talking about people. We've talked about this before in other conversations, where you've got people going, "Well, I read it in a paper, so it must be true." And you've even said it on some of your videos. You can make it into a peer-reviewed journal, and your study be complete trash. Like, it doesn't mean that it's a peer-reviewed journal that the results are generalizable to the person reading it. And a lot of people will often find papers that want it to prove what they believe. That's confirmation bias. And you will find those ones and say, there you go, I was right. When actually what you do need to do is you need to break these studies apart through critical appraisal. And that's the thing, like people don't really, I think, understand it's something that you have the luxury of, because you're taught that in medical school. And I had the luxury of, because I was taught that on my master's in medical science and my background. I also had a job in medical research as well. And I've also undertaken further training with a group which I'll just show on screen now, just because they're so valuable, because it's at home learning, called the Critical Appraisal Skills Program. So if you're interested in looking, and this is put together by a bunch of emergency medicine physicians from a city called Bristol in the UK that noticed that when it came to people saying why they were doing things in terms of clinical management, specifically in the emergency room they worked in, they were like, well, because that's what my clinical supervisor taught me to do.
Of course, of course.
Yeah, and that's it's a good answer. But why are they doing it? And they're like, well, I read a paper on this, and they're like, oh, well, was it a good one? And they're like, well, yeah, it was in the Lancet, so yeah, I'm sure it was good. And it's like, well, is
not
it
necessarily?
So this course is something that I've done it, and I'd highly recommend to anyone that's interested in learning how to critique literature, because you get 6 months to go through all of the podcasts, and they will have linked papers, and they will teach you the differences between a relative risk and an absolute risk, or the difference between an odds ratio and a risk ratio, or a confidence interval, and how that impacts on whether your study is valid. And then it talks about the differences between internal validity within the study and then external validity to generalize to your population that's being studied. So yeah, it's they're a great resource that I'd highly recommend to anybody.
I will take advantage of that. And you're absolutely correct. I mean, the ability to critically analyze a scientific study is really difficult. I even with graduate level biostatistics courses in medical school, 6 years of combined residencies with journal clubs where that's what you do is dissect. I still consider myself a novice in that area.
Me too. Like
really, because it's so complicated. It's really challenging to tease things apart, and then even then try to apply it to the person who's sitting in front of you, who may not be anything like the test subjects that were in that paper.
Yeah, exactly. Yeah,
it's hard. It is really hard.
I have an interest in doing that, and I actively practice it, because I never like to go into clinical practice and hear someone say, "Oh, I read this paper. Should we try this?" And I'm like, "Which one? Let me just have a quick look at it before we try something." There are rules to this kind of thing, and it's and then when you look at it, you're like, "Oh, this paper's absolute crap, like rubbish." Like it's no, we're definitely not trying that. It's like
there's an old there's a quote I like from Arthur Jones, who was he created the Nautilus machines, and he's kind of an old curmudgeon. He's been dead for a long time now, but I think his quote is something like 90% of everything that's ever been written on all subjects is hogwash.
You know what? What's terrible is it's not that inaccurate.
It's probably pretty close. Maybe he's being charitable. I don't know. Maybe it's actually worse than that.
It's probably more. Yeah.
So it's you have to be critical, and it is. That's the hard part about this entire field is there isn't enough information. There's not enough good studies in TRT, and the ones that are out there are sort of poorly done. I'm going to do a video today when we get done. After this, I'm going to the gym because I'm highly motivated now. But when I get back home today, I'm going to do a talk about. I'm going to put out a video on atrial fibrillation and testosterone therapy, and the relationship between those two.
I read that paper recently.
The Traverse trial, right? And there's surprisingly very little on that, but it's very difficult to come up with an obvious conclusion because it's very muddy, and so. So anyway, I'm going to do a video on that coming up here after we
definitely more study needed on that, and the unfortunate thing is, because of the heterogeneity of those types of problems, it will require logistic regressional analysis, which in and of itself can miss things, can't it? So it's if listeners out there don't know what that is, go and check out that CAS course. They talk about that.
I'm actually going to take that. I am going to take that course, Felix, because I'm glad you showed that.
It's great. It's really good. It's really good.
Really, really good.
You make a valid point, because we have a lot of scientific literature on testosterone replacement therapy. Say the fair majority of it was originally authored to justify the treatment of healthcare systems that don't understand what the problem is.
Exactly.
So what we need is more studies that look at the more, they're not even that novel anymore, but the more novel therapies, the ones that are, they're logically better than, we say, giving someone gel once a day for 5 days a week, which is just a horrible protocol. But it's in the NHS in the UK today. Like, it's just, we need more studies where we look at, in very controlled ways, at all the different esters and how they apply to different subsets of people.
Mm-hmm. Yeah, and we may never get that. I don't know. We'll just have to see. But unfortunately, what happens though is that, and I've been guilty of this too. We all have, because we're busy. But someone, a provider will look. They'll just read a line from the abstract. And say, and it'll say TRT was associated with increased risk of atrial fibrillation. And then and that's just from the abstract, but they won't actually go into the paper.
All their friends saying it is, and it's like, whoa.
Yeah. And then
maybe one day you and I could collaborate, and we can put out some education that will hopefully steer things in the right direction.
Well, that's going to happen. That's going to happen at some point.
Watch this space, everyone.
That's right. Well, Felix, thank you so much for coming on. You and I could talk all day for many hours about this stuff, and we will do this. We will in the future. We'll do more of these, because I love your perspective on this. It's also really refreshing to me to see how things are done in the UK versus in the United States. We struggle with the same issues in terms of the mainstream medical community understanding what we do, what our motivations are, and our approaches, and that seems to be something that we share. But
it's a commonality for sure.
It sure is, but I love to see that there are now places like the Eden Clinic that are serving your population over there, which I know is every bit as unhealthy as ours over here, and has the same needs that we do here. And
a lot of metabolic problems here as well as America.
And people are suffering, and men. We focus on men, of course, but I don't want to forget that women have the same issues, the same sort of struggles that are manifested in slightly different ways. Just like the men do, but they suffer in silence. They're, as we talked about in the very beginning of this podcast, they're often just dismissed by the medical community, whether it's primary care or even sometimes the endocrinology and urology world. I like to think that things are slowly changing, but there are still, hundreds of thousands, if not millions of men. I'm sure it's in the millions all over the world that could benefit from, what the kind of medicine that you and I are trying to practice. So
I agree completely.
Hopefully things will change.
We'll try and make sure of that.
So once again, if you're in the UK, Eden Clinic for Men, please go ahead and check it out. You do. You have a telemedicine service.
So I work remotely for the clinic, but we do also have the premises, obviously, in Plymouth, which is down in the southwest of the UK. So if you're a local resident, you can drop in, please do, and speak to the owner operator, Dr. Angela Service. We can also set up remote conversations with myself and her, and we can talk about what we can do for you.
All right, thank you, guys. Please leave some comments. Let me know what you think, and leave some questions. If you have questions for Felix, put them in the comments section.
Sure. You can use our contact page on www.edenclinicformen.co.uk.
Okay, and I'll put contact information in the show notes. And if any of you guys would like to set up a consultation with Felix, I would highly recommend it. He's one of the few providers out there in the world that I would trust my own healthcare with, and that of my family. So he gets the official
and likewise
endorsement, seal of approval.
Thank you, Andrew. And likewise, I'd be the same with my care with you.
All right. Well, we'll chat soon. Take care.
Take care.
Bye-bye.